Good afternoon, everybody. I'm Dr. Jamie Mitchell. I'm an endocrine surgeon who works at the Norman Parathyroid Center, where I'm the medical director, and I'm the director of the Division of Parathyroid Surgery at the Hospital for Endocrine Surgery here in Tampa, Florida. We have the highest volume center for parathyroid surgery in the world, where we do between 3,000 and 4,000 parathyroid operations each year. We're going to do a question and answer session today, so thank you for everybody who's attending. If it's your first time, welcome. Those of you who've been here before, welcome back. Again, thank you to everybody who sent the questions in. A lot of great questions have come in. You can submit questions while you watch, and we'll try to get to them, but we have quite a few already, so we'll do the best we can. And I better get started to get through all of these. So to begin with, this one came in. Hopefully this person's actually watching, but will this live Q&A be recorded for patients who can't watch in real time? The answer is yes. All of the Facebook Live question and answer sessions that we do, including today, are recorded and they're posted on our Facebook page. They also are posted on our YouTube channel. So you can watch this one, you can watch all the ones we've done in the past, and review it at your leisure. Okay, into the clinical questions. Here's a good one. What is the difference between primary, secondary, and tertiary hyperparathyroidism? Great question. This is kind of a source of a lot of confusion amongst patients, and to be honest, it was confusing for a lot of people in medical school when they're trying to learn the difference. But here's the primary difference. Primary hyperparathyroidism means that one or more of your parathyroid glands are diseased and they're overproducing parathyroid hormone. Just quickly, for those of you who don't know, the parathyroid glands make a hormone called parathyroid hormone that is responsible for regulating your calcium levels in your bloodstream. Specifically, this hormone corrects low calcium levels back to normal. And so people with primary hyperparathyroidism have one or more diseased, overfunctioning parathyroid glands. They are not normal. They overproduce parathyroid hormone, which typically leads to hypercalcemia. And there are consequences to that to your health over time. Specifically, your risk for having renal failure goes up, your risk for having a stroke is higher, your risk for having a heart attack is higher. And one of the ways that parathyroid hormone makes more calcium available in the bloodstream is to take it from your skeleton. So accelerated bone loss and the complications of osteoporosis are another complication of this disease. So that's what primary hyperparathyroidism means. Secondary hyperparathyroidism means you have elevated parathyroid hormone levels, but your parathyroid glands are not diseased. You have normal glands that are making more hormone than usual in response to some other condition. And there are several common conditions that can do this. For example, people with advanced renal failure or end-stage renal disease who are on dialysis all develop secondary hyperparathyroidism because the conditions of renal failure stimulate the parathyroid glands to make more hormone to compensate for a number of things: low calcium, low vitamin D, high phosphate levels. Another common reason for secondary hyperparathyroidism is severe vitamin D deficiency, where the glands make more parathyroid hormone to compensate for that low vitamin D. Another is malabsorption. So there's a number of things that can cause your PTH levels to go up. Typically, in those patients, their calcium levels are normal or low, sometimes low normal. They do not have elevated calcium levels. That's what you see in primary hyperparathyroidism. An important thing to note is that almost all cases of secondary hyperparathyroidism are managed medically. They are not surgical diseases where they benefit from surgery. Primary hyperparathyroidism is different, where the only treatment is surgery, okay? Tertiary hyperparathyroidism refers to patients who have secondary hyperparathyroidism due to renal failure. So these are patients on dialysis, usually for a number of years. And typically their parathyroid hormone levels are high because their calcium is really low, their vitamin D levels are low, as I said before. Sometimes these glands, which are normal, are stimulated for so long that they become so overfunctioning that calcium levels actually become elevated. And that's called tertiary hyperparathyroidism. We see this most commonly for people who have been on dialysis for many years who get a kidney transplant. When their physiology normalizes, most of the time parathyroid hormone levels go back to normal. The glands kind of rev down and start acting normally again. But in some patients, they've been stimulated for so long, they simply can't go back to normal. And so once your renal physiology normalizes, calcium levels shoot up and become elevated. Those are the main differences between those three. It's a good question. Kind of along those lines, the next question is, can you explain normal-calcemic primary hyperparathyroidism? Does this mean your disease is more mild or earlier in its development? We get a lot of questions about normal-calcemic primary parathyroid disease. What does this mean? In most patients with primary hyperparathyroidism, their calcium levels are elevated for the reasons I mentioned before, okay? Typically, or under normal circumstances, parathyroid hormone is responsible for correcting low calcium levels back to normal. In patients with primary hyperparathyroidism with a diseased overfunctioning parathyroid gland, this hormone is overproduced. And so instead of correcting low calcium levels back to normal, your calcium levels become elevated. In most patients with this disease, there is a subset of patients with primary parathyroid disease where their calcium levels never measure above normal. And it's a less common form of the disease. It's a bit harder to diagnose. And the reason it's harder to diagnose is because it has to be distinguished between or from patients with secondary hyperparathyroidism. Like I said before, the majority of secondary cases don't require surgery. They don't benefit from surgery. They're managed medically. Correction of low vitamin D, calcium supplementation, correction of malabsorption, etc. And so it's important to distinguish between primary and secondary because both of those patient types have high PTH values, but their calcium levels are in the normal range. So you have to make sure that secondary causes are excluded before coming up with the diagnosis of normal calcemic primary disease. In general, those patients have just as bad symptoms. The disease is not considered to be more mild. And it's really unclear if it's an earlier form of the disease because people with normal calcemic disease often go undiagnosed. And so that's a hard question to answer. But we get a lot of questions about normal calcemic primary disease. Hopefully that clears it up a little bit. If someone has kidney failure, what are the most important things they need to know before parathyroid surgery? I'm going to assume that this is people who have to undergo surgery for medically refractory secondary hyperparathyroidism due to renal failure. As I mentioned before, most cases of secondary parathyroid disease do not require surgery. One exception to this are patients who have been on dialysis for a long period of time where medical therapy of their high PTH values has failed. What do I mean by this? As I mentioned before, renal failure causes stimulation of parathyroid hormone secretion because of several things. Your calcium tends to be low, vitamin D is processed or metabolized in the kidney, and so vitamin D levels tend to be low, and phosphate levels are high. All of these things stimulate parathyroid hormone secretion to help compensate for that. This is managed medically by giving calcium supplements, vitamin D supplements, and phosphate binders. That's standard treatment of nephrologists for people on dialysis. In some cases, those medical therapies fail and parathyroid hormone levels become so high that they are problematic and cause health-related problems like cardiac morbidity, etc. We're talking about PTH values above 1,000. When that happens, nephrologists will often refer those patients for surgical treatment. And those patients require what's called a subtotal parathyroidectomy. All four of those of the parathyroid glands are affected by this. They're all very enlarged, over-functioning. And the only way to fix the problem is to do an operation where 3 and a portion of the 4th gland are removed. What's the most important thing that patients need to know before this operation? That's one of them, that your operation will require a subtotal parathyroid resection. And it's very important to have close follow-up with your nephrologist after surgery to keep a close eye on your calcium levels, which will tend to run fairly low for a period of time. Good question. Here's the next one. What if my calcium is high, but my PTH is within the normal range? It's a great question. It's a common source of confusion. It's a common reason why diagnosis can be delayed for primary hyperparathyroidism. The answer to the question is you most likely have primary hyperparathyroidism. And here's the concept. As I mentioned before, the only reason that you secrete parathyroid hormone is when your calcium levels are low. They're too low in your bloodstream. And that's the only job of parathyroid hormone, is to correct those low calcium levels back to normal. If your calcium levels are elevated and your parathyroid hormone level measures in the mid to high normal range, even though it isn't elevated, that's not normal for that calcium level. Again, if you only make parathyroid hormone when your calcium is low, if you're hypercalcemic, you shouldn't be making much parathyroid hormone at all. It should be in the very low normal range or suppressed. So about 20% of patients with primary hyperparathyroidism have this type of biochemistry where their calcium levels are persistently elevated, but their parathyroid hormone levels measure within the normal range. And it's one of the most common reasons for misdiagnosis or lack of diagnosis for this disease, where doctors will notice the high calcium, they'll check a PTH, which is great, it's the right thing to do. They'll see that it measures within the normal range, and then they'll say, oh, you don't have this problem, it's not your parathyroids. That's not correct. If it's in the mid to high normal range in the setting of high calcium, this is still primary hyperparathyroidism, okay? And that's the concept. It's a good question, we get it all the time. The next several questions, I think, are all related to parathyroid imaging, so I'm going to try to do them in order. The first one is, if SESTAMIBI scans, this is a common imaging test. It's a nuclear medicine X-ray that is often obtained for parathyroid disease. If a SESTAMIBI scan is negative but labs clearly point to hyperparathyroidism, what should patients do next? The important concept here is that imaging tests like SESTAMIBI scans or ultrasounds or CT scans, these are the common imaging tests that are obtained for parathyroid disease. They are not sensitive enough or specific enough to be useful for the diagnosis of this disease. They shouldn't play any role in making the diagnosis. That is entirely based on a patient's lab data. So primary hyperparathyroidism, again, to reiterate, is diagnosed entirely based on biochemistry, biochemical profile, laboratory data, specifically the relationship between your calcium levels and your parathyroid hormone levels. So if your doctor makes the diagnosis, which is great if they actually notice that your labs are abnormal, make the diagnosis and send you for imaging, but your parathyroid scan is negative, or your ultrasound doesn't show anything, or whatever, and they tell you, oh, your scan was negative, you're okay, you don't have this problem. Do not listen to that. That's not correct, okay? Imaging tests are often negative. As I said, the sensitivity overall is pretty poor. And while they're a tool that is often used for the management of this disease, it should never be to diagnose the disease or to decide whether you should be treated for the disease, okay? That goes for all of the imaging tests that I mentioned. Similar question, if all imaging is negative, but blood tests clearly show hyperparathyroidism, and this has been present for years, what happens next? How is surgery planned when scans don't show a clear target? As I mentioned, the results of imaging tests shouldn't really play a big role in the decision, the diagnosis of this disease or the decision to treat. Many surgeons who treat this disease do or prefer to do what's called focal parathyroid surgery. That means they hope for an imaging test to tell them which gland is abnormal, and then they remove that gland during surgery or try to, and then check parathyroid hormone levels before and after they remove that gland, hoping to see an appropriate drop. The problem with this approach, we feel, and that's why one of the reasons we don't do that approach to surgery in this practice, is what I've been mentioning, is that parathyroid imaging tests like SESTAMIBI scans and ultrasounds and CAT scans are notoriously inaccurate for predicting which gland needs to be removed or how many need to be removed. And so if you use imaging results like this to guide your surgery or tell you what operation to do, you are going to do the wrong operation far too frequently, up to 30% of the time. That's why our approach to surgery is to not use imaging results to guide the operation. We always identify and evaluate all 4 parathyroid glands regardless of imaging results. And in that way, we can ensure that our patients get the most complete surgery possible and the highest chance for cure. Next question. Again, similar. What does it mean when imaging studies don't agree? For example, ultrasound shows one gland, but a SESTAMIBI shows another gland. This is really common for the reasons that we've been talking about. Imaging technology is relatively inaccurate for this. And so it's not uncommon for different imaging tests to disagree with each other. Again, this is why in this practice we don't use these results to tell us what operation to do, because as you can see, it can be very confusing. Another test, again, there's another question about imaging tests. If an ultrasound suggests an adenoma but SPECT CT is negative, is that unusual? Which test is more reliable? How do specialists interpret conflicting results? It isn't common for them to disagree, as we said. Which test is more reliable? They're all about the same in terms of their sensitivity and specificity, actually. And how do specialists interpret conflicting results? I'm not sure what other surgeons do, but in this practice it doesn't matter because we're going to evaluate all 4 glands anyway. Next question, is there a non-surgical or minimally invasive way to cure hyperparathyroidism if someone cannot have surgery? Unfortunately, the answer is no. There's no non-surgical treatment for primary hyperparathyroidism. It's a surgical disease, so there's no pill that exists that can treat it. You may read about a medication called cinacalcet or Sensipar. This is a calcimimetic drug that was developed for the treatment of renal failure-related parathyroid disease, which I was talking about earlier. Surgeons argue that it doesn't really treat that disease either, but it certainly has no known benefit for treating primary hyperparathyroidism. The only role for this drug are for people who are so sick that they can't undergo an operation, which is pretty rare, frankly. You can have pretty significant cardiopulmonary comorbidities and tolerate this operation without much trouble. So we don't run into that very often, but there are certain patients who can't be cured of their disease for various reasons, and if their calcium levels are dangerously high, close to 13 or 14, for example, then cinacalcet or Sensipar, this drug, can at least sometimes lower those levels to, so that they're not life-threatening. But in general, there's no non-surgical way to cure this disease. Good question. Next one. If vitamin D is low, why can't we just take vitamin D to lower PTH and to let calcium levels correct themselves? It's a great question. We get so much confusion about vitamin D and its role with this disease. To review, so parathyroid hormone, okay, like I've said before, its role is to correct low calcium levels back to normal in your bloodstream. It does this 3 ways. Okay, one of the ways it does this is by activating cells in your skeleton called osteoclasts. These secrete enzymes which break down your bone mineral. One of the important parts of your bone mineral obviously is calcium, and so that releases these things into your bloodstream and can make more calcium available in the blood. It also acts in the kidneys by acting on the kidney tubules so that you don't pee out as much calcium, you don't lose as much in the urine, you hold on to more of it in your bloodstream. That makes more calcium available in the blood. Finally, it activates vitamin D. It converts 25-hydroxyvitamin D to its active 1,25-dihydroxy form. And so if you have hyperparathyroidism, you're overproducing parathyroid hormone, you're constantly converting your vitamin D to the 125 form. This depletes the 25-hydroxy form, so it lowers it in your bloodstream. So when your doctor measures your vitamin D and you have hyperparathyroidism, it often is low. And so often what we see doctors tell their patients, including endocrinologists who should know better, the patient has high calcium, they have a high PTH, and they have a low vitamin D, and they say, let's correct your vitamin D and see if this fixes your problem. While vitamin D deficiency can cause high PTH values, like we talked about when we were discussing secondary hyperparathyroidism, vitamin D deficiency can never cause hypercalcemia. So if your calcium's elevated, repleting your vitamin D levels will not fix that problem ever. It'll actually make it worse. That's the important point. Vitamin D, 25-hydroxyvitamin D, which is what your doctors check when they're measuring your general vitamin D levels, is often low with primary hyperparathyroidism because the overproduction of parathyroid hormone is converting it away to a different form and depleting it. So if you have high calcium, that's the key, and your vitamin D is low and your PTH is high, vitamin D repletion will not solve that problem, ever. It'll make it worse, okay? We get this question every month that we do one of these. What are your thoughts on PET scans for locating parathyroid adenomas? What are the pros and cons? PET scanning is not a common imaging modality for parathyroid disease. The common PET scan that people think about is called an FDG PET. That's usually used for detecting cancer in the body. There is a type of PET scan that can be used for parathyroid localization. The radiopharmaceutical is different. It is C11 choline. But this radiopharmaceutical is difficult to manage, and this test is not available very many places. In fact, the only place in this country that I'm aware that does it is the Mayo Clinic. I do use this imaging test specifically for complicated reoperative cases where traditional imaging tests have not been helpful. And I probably will not be successful if I operate on this patient without a clear localization target. So in this specific circumstance, I have sent a number of patients to the Mayo Clinic to get this test, but it's not a routine test to get for parathyroid disease. Next question, what is the connection between MEN1, that stands for multiple endocrine neoplasia syndrome type 1, and hyperparathyroidism? MEN1 is a hereditary form of parathyroid disease. This is caused by a specific mutation to what's called the menin gene. This is an autosomal dominant condition. That means if you have the disease and you have children, they have a 50-50 chance of getting it. And this disease causes a number of, neuroendocrine tumors. Hyperparathyroidism is one of them. Pituitary tumors, the most common being a prolactin secreting tumor of the pituitary gland, and neuroendocrine tumors of the pancreas. It's a pretty rare disorder, but patients with MEN1, 100% of them get primary hyperparathyroidism. And it's important to note that MEN-related parathyroid disease always involves all four glands. These are not adenomas. This is a case or situation of parathyroid hyperplasia where all four glands are affected. It's a rare disorder. We do see it. It's an interesting disease. Endocrinologists get really excited when they have patients with MEN1, but that's the relationship to parathyroid disease. There's an MEN2 as well, which has a different constellation of tumors, including parathyroid disease, medullary thyroid carcinoma, and pheochromocytomas of the adrenal glands. It's important to note, though, the overwhelming majority of cases of primary hyperparathyroidism are due to sporadic disease, meaning there's no genetic component, okay? Next question, if imaging shows a thyroid nodule, how often does that turn out to actually be a parathyroid gland hidden within the thyroid? The answer is usually not. Most masses within the thyroid are primary thyroid nodules. However, parathyroid tumors or parathyroid glands and abnormal glands can be within the thyroid. So one of the reasons we do ultrasound exams as a surgeon before every case that we do is to look for those types of things. With experience, usually you can tell the difference between a thyroid nodule and an intrathyroidal parathyroid tumor. But it's important to know that before you begin the operation because you can't see inside the thyroid with your eyes. So ultrasound is a very important tool preoperatively before each case that we do, and that's one of the things that we're looking for. Let's see. How soon do symptoms like bone pain, brain fog, like neurocognitive deficits, that refers to short-term memory loss or difficulty concentrating, headaches, chronic fatigue, how quickly do they usually improve? It's a great question. It varies a little bit, but typically symptoms improve or people notice an improvement in symptoms if they are related to their parathyroid disease within a few days to a few weeks. Bone pain actually is the first thing to go. It goes away almost instantaneously after successful surgery. It's like you turn a switch off and bone and joint pain is gone. The other things can be as fast. I've had patients actually wake up on the operating room table coming out of anesthesia and notice a difference. But typically the other symptoms, people notice improvements in those within a few days to a few weeks, that kind of time frame. So relatively quickly. After surgery, how long does it usually take for bones to start recovering in patients with bone loss or osteoporosis? The process begins immediately, actually. So that's one of the reasons that bone pain goes away so fast, because that activity of the hormone on the skeleton goes away immediately when the hormone levels drop. And so one of the reasons, we all give all of our patients calcium supplements after surgery because calcium levels tend to run a little low for a couple of weeks. One of the reasons for that is If you have a parathyroid tumor and 3 other normal glands, those normal glands, number one, haven't had to make hormone for quite some time, so it takes them a little bit of time to start that machinery up again. The other reason is that your skeleton, which has been losing calcium continuously for whatever period of time you've had the disease for, suddenly can do the opposite. Suddenly that signal is gone and it starts to siphon calcium out of your bloodstream back into itself. And so that's one of the reasons that calcium levels tend to run a little low for the early period after surgery. So that process begins immediately, but appreciable changes in bone density usually takes a number of years after surgery. If someone had multiple glands removed, what are the chances the remaining gland will cause problems in the future? It depends a little bit what you mean by multiple glands. If you have 1 or 2 parathyroid tumors found during surgery and 3 or 2 normal glands, and you've had them all evaluated and had a thorough surgery, the chance of recurrence is less than 1%. It does occur. Some people are unlucky and develop another tumor down the line, but it's pretty unusual. Most of the reasons for early recurrence after surgery are because they had a focal operation and all the glands weren't evaluated. Next question, when symptoms are gone, labs are stable, so presumably someone's had an operation that was successful and they're cured, is it necessary for a patient to continue routine follow-ups? I'm assuming this means lab follow-ups. Typically, we have patients get a routine set of labs 1 to 2 months after surgery. We know whether they're cured or not based on the parathyroid hormone level we check in the recovery room and the findings during the operation. We do a routine set of labs a month later just to dot all the I's, so to speak. If those labs look normal, then there's really no reason for additional follow-up, other than routine labs that you get with your annual checkup. Again, it's possible you could develop another problem with parathyroid disease down the line, but it's unlikely. Let's see, if parathyroid disease comes back after surgery, this is kind of along the lines of what we just were talking about. If parathyroid disease comes back after surgery, how often is that a true recurrence versus the disease being missed the first time? Again, if you've had a thorough operation, meaning you've had all 4 glands identified, you had a tumor removed, and you're cured, recurrence is pretty rare, but can occur. Usually the timeline is, a number of years. More than 5 years is typical. If you have abnormal labs within 6 months, that is the definition of persistent disease. But frankly, if you develop another, clear evidence of parathyroid disease within a couple of years of surgery, I would say that's more likely persistent disease than recurrence. There's another vitamin D question. I think we covered that. Okay, this is a good question. I've read a lot on your website about 4-gland exploration. Wouldn't that be a larger surgery? Why is that better than going after only the 1 gland identified on imaging? I think I've sort of covered that answer with the previous imaging questions, but we can reiterate it. The reason that we believe in 4-gland evaluation and identification in each operation is because, again, imaging technology is notoriously inaccurate. What's available now, inaccurate in terms of predicting which gland needs to be removed or how many need to be removed. The sensitivity is relatively poor, meaning sensitivity means you have the disease and something shows up on your imaging test. And so there are plenty of people who clearly have hyperparathyroidism where nothing shows up on imaging. So the sensitivity is relatively poor. The specificity is relatively poor as well. That means that you don't have the disease and nothing shows up on imaging. The problem is a lot of imaging signals that we see have nothing to do with parathyroid glands, that they're false positive results. And so again, I've done reoperations on many patients where surgeons went after signals on scan and it had nothing to do with parathyroid disease. And so they ended up not being cured. So again, that's why this practice has developed the approach to this surgery where we use imaging tests, but it is not to tell us what operation to do, okay? It's important, we feel, because of the limitations of imaging, that all 4 glands are evaluated, because 30% of the time, people can have more than 1 abnormal gland, and they almost never both show up on imaging, etc. Okay, we've talked about that concept quite a bit. I've seen a lot of reviews of folks who have traveled across the country to have surgery with you. Can you help me understand why someone would do that? What's the difference between surgery with you or a local ENT? Some of the things we've already talked about. Okay, our approach to the operation is unique. Our ability to evaluate parathyroid glands functionally in real time is unique to this practice. Most surgeons, again, do focal parathyroid operations based on imaging results, which can be misleading, using intraoperative parathyroid hormone level measurements to predict whether they're successful or not. We believe that's not the best way to do this operation, leading to a lot of non-cures. Whether that's immediate or within a year or two, to us that doesn't make a difference. The other thing that's important is experience with this operation. And so the parathyroid anatomy and embryology can be fairly complicated. There's quite a bit of variability in terms of where these glands can be located. There aren't too many surgeries that surgeons do where you have to hunt for the organ that you're operating on. But you do have to do that with parathyroid surgery. So there's quite a bit of variability and you need to have a lot of familiarity with that. So there's quite a few curveballs that the disease can throw at you, and you have to have a lot of experience to be able to handle those curveballs. When you do, for example, this year I will, after the next 2 weeks, have performed just under 650 parathyroid operations this last calendar year. And I've done probably close to 13 or 14,000 in my career now. That makes a big difference in terms of being able to handle the unusual things that you can see with this disease. That's the best way I can explain why people decide to travel to have surgery at our center. Experience really matters. And it's much more difficult to cure this disease when you've had an unsuccessful surgery. Reoperative parathyroid surgery is much more difficult. And that's why a lot of people, after thinking about it and reading about the different approaches, will come to our center. Okay, if calcium and PTH levels are clearly elevated but access to an endocrinologist is delayed, what steps should patients take in the meantime? It's a common problem that we hear about. It takes a long time to get in to see endocrinologists. The wait can be several months, sometimes 6 months. If you have a clear diagnosis of primary hyperparathyroidism, endocrinologists can't really do anything more to help you. This isn't to knock endocrinologists, but as I said before, it's a surgical disease. So if you have a good primary care doctor who's made this diagnosis, the endocrinologist can't really help you other than to confirm the diagnosis and then refer you to a surgeon. So rather than waiting months to see an endocrinologist, I would recommend seeking out or getting a referral from your primary care doctor to the most experienced parathyroid surgeon that you can get. Okay? Okay, so these are some more that have come in. Is follow-up different for removal of 1 gland versus 3.5 glands due to hyperplasia? Do you expect the half gland to be able to do its job? The follow-up isn't really different, actually. It's the same sort of routine follow-up lab work that we recommend for patients, whether they have 1 or 2 or a subtotal resection like you're mentioning. Do we expect the half gland to be able to do its job? Of course. I mean, that's the key to that operation, is knowing how to subtotally resect a gland while keeping its vascular supply intact. That's again why you come to an experienced center who does a lot of the surgery. With experience, it's not a problem to be able to do that. But the follow-up isn't any different in terms of lab work, how frequently you need lab work, the recovery, all those things. It's very similar. Okay, I'm being told this is my last question. I have hyperparathyroidism, but have had several neck surgeries already. My doctor says no surgery because it would be like trying to find a grape in a block of cement. Okay. What are the options for me? If I had $5 for every patient that I've operated on successfully, who was told the same thing, then I wouldn't have to be doing these Facebook Live sessions anymore. The truth is, while difficult, and while not all of these patients who've had a number of neck surgeries can be cured, it can be quite challenging. With experience, many of these cases can be solved, and I think the most operations that a patient has had before they found their way to us, or me specifically, was 8 unsuccessful parathyroid operations spanning 30 years. and they finally found our center, and I was able to operate on that patient and actually cure them. So it is possible. And so there's no reason not to be evaluated. I would recommend that you go to our website, parathyroid.com, do the intake form, let me evaluate your case and see what we can do. There's a decent chance we'll be able to fix your problem. I certainly will welcome the challenge, okay? That's all the time we have, I'm being told. Thank you again for everybody who joined us. Thanks for all the questions, they're really great, and they help everybody. I get patients here every week who talk about how much seeing these sessions on our YouTube channels helps them. So until next time, we'll do this again in another 6 weeks or so. Have a great holiday, everybody. Thanks for joining, and have a great rest of your afternoon.